Hi, I'm Reshma and I'll be talking about thyroid. So basically, thyroid is an important topic in surgery. We might have essays, short notes, or there is even a case. And even in medicine, thyroid is an important thing. But here, the important questions are, uh, clubbed. It is also about the endocrine chapters as well. But here, it is entirely of thyroid. So these are the important questions. So this video will be we'll be first talking about all the basic things in thyroid, like embryology, anatomy, and physiology part. And then on subsequent videos, we'll be talking about a case and then a related essay. So that is how we cover. So first, let's talk about the embryology of thyroid gland. So basically, thyroid gland develops from the first and second pharyngeal pouch. It is actually near the buccal cavity, and then it actually descends down to reach the neck area. So first, it will be related with the foramen cecum, which is from where the tongue and all develops, and later on it just descends. So if you see this picture, so it descends down by forming a thyroglossal duct, and this thyroglossal duct will actually disappear when we grow up. But then, if it remains, that is when this thyroglossal cyst develops, and that is when that comes. So thyroglossal cyst is basically, it'll usually be a small swelling which will usually be in the midline. So that is how you can find out. Whereas a normal thyroid swelling like a goiter or something like that will not necessarily be in midline. It can involve any lobe of the thyroid, no? So it can be on the lateral side as well. So that is the importance of knowing this. Then, if you see, this is the picture given in the baby, and if you see here, your parathyroid glands, which are behind the thyroid glands, the four parathyroid glands, actually develops from the third and fourth pharyngeal pouch. So this inferior parathyroid gland develops from the third pharyngeal pouch along with the thymus. So this is the thymus. So that is when, so this is the direction at which it, descends. Descends down along the thymus to reach that area. And this is the direction in which the thyroid gland descends down. So yeah, next thing. Then if you see, thyroid gland is actually covered by fascia, capsules. So it has a true capsule, it has a false capsule. True capsule is a deeper capsule which is attached just to the gland, and false capsule is actually a superficial capsule. True capsule is nothing but just the condensation of the connective tissue which are there in the thyroid gland. And the false capsule is actually the pretracheal layer of deep cervical fascia. So if you see, thyroid gland is basically very vascular structure. So there's a lot of arteries and veins supplying it. And if you see here, the plexus of veins which are supplying the thyroid gland lies deeper. So that is why when you're doing a thyroidectomy, when you want to remove the whole thyroid, we will not touch the deep capsule. We'll actually remove it along with the deep capsule. So this is the area between the true as well as the false capsule, that is the deep as well as the superficial fascia, is the avascular area, that is the plane of cleavage, that is where you incise, put your incision on. Then talking about the blood supply of thyroid is supplied by the superior thyroid artery, it's supplied by the inferior thyroid artery, and then there is one more artery called thyroidea ima artery, which is not seen in everybody, it's just in 30% of individuals, and that is a direct branch from the aorta. While superior thyroid artery is a branch of external carotid artery, and inferior thyroid artery is a branch of thyrocervical trunk, which is a branch of subclavian artery. Then talking about the veins, venous supply. So that just follows the artery. You have superior thyroid vein, inferior thyroid vein, as well as one different vein is the middle thyroid vein. And what is the significance of knowing middle thyroid vein is, it is the first vessel to be ligated during a surgery, during the thyroidectomy surgery. So that's the importance of knowing it. Then, yeah. So if you say just about thyroid is basically a butterfly shaped structure which is located between the C5 to T1 vertebrae. And then it is actually called as a shield. Why in Greek? Why? Because it has so much function. It actually protects us from a lot of things. It regulates the basal metabolic rate and a lot of things it does. So that's why it's called shield. And it weighs around 20 to 25 grams. Yeah. So these are some of things, general things that we have to know. Then talking about the nerves that supplies, we've got recurrent laryngeal nerve, the right and the left recurrent laryngeal nerve, and then we've got the superior laryngeal nerve, which gives the internal branch as well as the external branch. Okay, so if you see the difference, the left recurrent laryngeal nerve is actually longer because it actually winds around the arch of aorta, while the the recurrent right recurrent laryngeal nerve is actually shorter because it just winds around the trunk, the thyrocervical trunk. Yeah. The subclavian artery. So yeah, that is a course. And then if you see actually recurrent laryngeal nerve, if it gets bilaterally, if it is injured, it is actually very deadly, with dangerous because it can cause aspiration and all. But unilateral is fine. And we will usually say that recurrent laryngeal nerve injury is more common in thyroidectomy, but actually the external branch of superior laryngeal nerve injury is actually common. So how do we actually locate the recurrent laryngeal nerve and external laryngeal nerve and all during the surgery? We've got triangles for it. So we've got Baer's triangle and we've got Joel's triangle. What is Baer's triangle? Baer's triangle is located in the inferior part, and Joel's triangle, it's actually Joel, Joll, is located in the superior part. Baer's triangle, on the base you have this carotid artery, common carotid, and superiorly this arm you have the inferior thyroid artery, and then here you've got the recurrent laryngeal nerve. So this is the boundary, and this is how you locate the recurrent laryngeal nerve. And Joel's triangle, if you see laterally, it is from the superior pole of the gland. This is the lateral. Laterally, it has the superior pole of the gland and then the superior vessels. And then medially, it is in the midline. And superiorly what? Yeah, okay, the strap muscles. And then on the floor, you've got this cricothyroid muscle. And Baer's triangle is also called as Riddle's triangle. So yeah, so these are the triangles that we have to know. Another question that they'll ask is, what is the common site for a recurrent laryngeal nerve injury? That is this region. So for that, we have to know what is this. What is ZT? So this is the gland, and it posteriorly it will actually form a projection that is called as tubercle of Zucker-Candle. It is at that area where the recurrent laryngeal nerve injury is more common. Another area which is more common is the Berry's ligament. So what is Berry's ligament is, basically our thyroid gland is covered by the pretracheal fascia. When it covers, posteriorly it will actually condense and it forms the Berry ligament. So the condensation of pretracheal fascia posteriorly is what is Berry's ligament. And this ligament gets attached to the cricothyroid, and that whole complex will be attached to the pharynx. So that is why whenever we are swallowing, the thyroid gland also moves up with the swallowing. So that is also a question that they'll ask in Viva. Why does the thyroid swelling moves with deglutition? So this is the reason behind it. So basically, I'm coming to say that recurrent laryngeal nerve injury is more common at the site of this tubercle of Zucker-Candle as well as at the site of Berry's ligament. And then we should also know about the lymph nodes. So lymph nodes, the thyroid gland actually drains into this particular lymph nodes in the yellow color. That's called prelaryngeal nodes, also called as, it has a name, it is called Delphian nodes. Also called as cricothyroid nodes because it is actually anterior to the cricothyroid. It's located. So that is an important node for as far as thyroid is concerned. Also larynx also it drains into this, and from here the efferent drainage is to the paratracheal, this purple color, as well as this orange pretracheal. Okay, paratracheal and pretracheal. Paratracheal is also called as subdelphian nodes. And then these are the primary lymph node drainage, also the mediastinal. The secondary drainage is your superior deep cervical as well as your supraclavicular nodes over here. So these all becomes important during the surgical procedure when you wanted to, during the cancer malignancy of thyroid, when you wanted to resect these nodes also. So, and then if you see, this is the thyroid gland, and this is the relation, this is the carotid and all. Suppose, so usually we will be able to, for a normal person, we'll be able to palpate the carotid pulse when you place your thumb or your fingers on the anteroboreal sternocleidomastoid muscle at the level of C6 vertebrae posteriorly. But in case of thyroid malignancy, suppose if the tumor is actually invasive, like this over here, it is actually compressing the carotid, and we will not be able to feel the pulse when you touch also during a malignancy. So that is called as Berry sign positive. So that is Berry sign, when you're not able to feel the carotid pulse. Anyway, that these all will be explaining during a case presentation. But yeah. Then we have to know about some of the physiology of the thyroid gland. So for that in Bailey, this classic steps is given. This is what they'll ask in Vivo also. So we know thyroid produces two hormones, that is triiodothyronine as well as thyroxine hormones. And some people might ask you what is a colloid. We have colloid goiter and all. So they might ask you what is colloid and all. So if you see thyroid follicles, yeah, there are like around 24 to 40 thyroid follicles that we have in a thyroid gland, and inside them what you have is a colloid. Colloid is containing your T3 T4 hormones as well as the thyroglobulin from where the hormone is secreted. So all this is there in the thyroid follicle, the colloid. Okay. So that is what I was giving here. So what are the steps? So first is trapping of inorganic iodide from the blood. So from the blood, through the food, whatever iodide you're getting, that will be trapped, and through the sodium iodide importer, it is just moving in, and this iodide is actually converted to iodine by oxidation. So that's the second step, oxidation of iodide to iodine. Then the third step is binding of iodine with thyroxine to form iodothyroxine. So iodinization. So they, they will actually fuse with the tyrosine to form iodothyroxine. And after formation of that, they will actually coupling reaction happens. That is monoiodothyroxine and diiodothyroxines together. When they fuse, coupling reaction happens, and they will give rise to thyroxine and diiodothyronine. So T4 and T3 hormones are released back to the blood. Here they'll ask you, what is an important hormone? Is it T3 or T4? Actually, it is T3, because T3 will act very fast, and although T3 is produced by peripheral conversion of T4, T3 is actually a very important physiological hormone for us. And then we all know that whenever the hormones are produced, there is a negative feedback. There is a hormone called thyroid stimulating hormone, which is produced from the anterior pituitary, which will actually stimulate production of this. Whenever there is high amount of T3 and T4, automatically through negative feedback, this will become low. And again, this is regulated by thyroid regulating hormone, which is produced from the hypothalamus. I think that's it. So these are the basic thing we have to know.